We might start then. Good afternoon, and thank you for coming to the second seminar with Dr. Marion Kainer, who's the head of the HAI and AMR program at the Department of Health in Tennessee. Thank you, Marion.
So thank you so much for coming. I'm going to be talking about combating antimicrobial resistance in Candida auris. And hang on. Oh, that's how it goes. Okay. Hang on. How do I forward the slides on here?
Yeah.
Clicking on. Okay. So I started at the Tennessee Department of Health actually on Tuesday next week. It will be exactly 15 years that I have been there. And in 2003, when I joined, it was literally me, myself, and I. I was a one-person show. And at that time, my responsibilities included healthcare-associated infections, antimicrobial resistance. I was in charge of all of the public health informatics, including our state communicable disease surveillance system, as well as any outbreak management. I was in charge for viral hepatitis, not the perinatal portion, but adult hepatitis B and adult hepatitis C. And I was the principal investigator for the Epidemiology Laboratory Capacity Cooperative Agreement, which is a way that CDC funds state health departments primarily for programmatic work, not for research activities, but for programmatic work. Since that time, we have received significant financial support from CDC in the area of healthcare-associated infections and antimicrobial resistance. The Council of State and Territorial Epidemiologists and CDC has an applied epidemiology fellowship program, which is very similar to the Epidemic Intelligence Service, which is what I did before I joined the Tennessee Department of Health. I was an EIS officer at the Centers for Disease Control and Prevention in their Division of Healthcare Quality Promotion. The Epidemiology Laboratory Capacity Grant, for which I'm the principal investigator for the state of Tennessee, we had received a one-time bolus of funding through ARA, the Recovery Act, which really started our healthcare-associated infections program. It allowed me to hire some staff, some infection preventionists, and it allowed me to hire some epidemiologists. The Prevention and Public Health Fund, or PPHF, is under the Affordable Care Act. It now, to provide people context, when the United States, they're talking about repealing Obamacare or the Affordable Care Act, this Prevention and Public Health Fund is part of that. And it funds 30% of CDC. It funds the vast majority of state public health departments. And so we are always watching with a lot of anxiety what is going to be happening with regards to that. But the Affordable Care Act really helped to establish a healthcare infection coordinator within every state in the United States for the first time, to build some basic infrastructure on healthcare-associated infections. Then Ebola happened, and we actually received a 3-year bolus of funding, which allowed us to do infection control assessments at healthcare settings across the state. So we have done in-person detailed infection control assessments at hospitals, at nursing homes, at long-term acute care hospitals, at dialysis facilities, and at outpatient centers, and identified where there were gaps and tried to fill in try to mitigate those gaps. Really, really helpful. We really got our first certified infection control infection preventionists through that additional funding. That funding is due to finish in March of this year. And then there was this massive influx of funding in 2016 on antimicrobial resistance. We're also a state that is fortunate to be one of 10 emerging infection program states, which are states which are funded to do additional research with regards to emerging infections, not just deal with response and being programmatic, but actually doing a detailed research. So in 2018, my responsibilities are now, I'm only the Director for Healthcare-Associated Infections and Antimicrobial Resistance Program. The Public Health Informatics has grown to a group of 10 people instead of just that was all under my roof beforehand. I'm still the PI for the overall epidemiology lab capacity cooperative agreement. I would love to give that responsibility to somebody else. The budget alone is 700 pages. The narrative alone is 1,000 pages. And I have to go and do that on an annual basis with a lot of metrics associated with that. I'm also a principal investigator for the Emerging Infections Program, Healthcare Associated Infections Community Interface portion of that. So my team composes of 6 physicians, including myself. I have 2 pharmacists, including one very experienced pharmacist in the area of antimicrobial stewardship. I have 6 infection preventionists on staff. They're all certified in infection control. I have 9 MPH level epidemiologists. I have 2 administrative staff, 2 MPH students. I have a CSTE fellow, an APHL fellow, and we are hopeful that we're going to get a SHE IDSA fellow, one of the LEAP fellows, leaders in, gosh, I've forgotten what the acronym stands for, but they're trying to train infectious disease physicians to be trained in epidemiology, antimicrobial resistance, and in public health. And so it's going to be, we're hopefully going to be partnering with Vanderbilt University Medical Center with one of their infectious disease fellows who's going to be working partly at Vanderbilt and partly with us within my program. So we are in the process of writing that application. So this is a photo showing some of my team. Several are actually located outside of my central office. In Tennessee, we're a very long, thin state, but these are some of my team members here. We're a very diverse group of folks. And these are our partners at the state public health lab. And we actually had our governor visiting our state public health lab in September of 2016. Probably one of the only state public health labs that has ever been visited by a governor. And we have had significant support from the governor to expand our state public health lab to become one of the regional reference labs. We are a red state. We have a supermajority Republican legislature and we have a Republican governor. They are never for expansion of government, and to try and establish new positions really took a lot of convincing, but we were able to provide an argument for that, and we are very, very fortunate to have their support. So Mrs. Governor Haslam, and this very tall person over there is our Commissioner for Health. And we are very fortunate to have a very supportive Commissioner of Health, very supportive for healthcare-associated infections and antimicrobial resistance. Really bonded with our Commissioner and our governors predominantly through the fungal meningitis outbreak. That is where we really got to know each other really well. So there's been a tremendous momentum on antimicrobial resistance since 2013. So let me step you through some of this. This is the Antimicrobial Resistance Threat Report from 2013 that really captured the attention of the president, who looked at, we need to be combating antimicrobial resistance. And that was based on large part on this emerging infections program activity, where we performed a point prevalence survey of healthcare-associated infections in 183 hospitals in 10 states. There were 25 hospitals in Tennessee. This is probably the paper that has been cited the most, on which I am a co-author. Last time I checked, we were at 780 citations. So this was an absolute key underlying data to help create this antimicrobial resistance threat report, which then started the ball moving on everything else. So I had the fortune of participating in a working group on antimicrobial resistance for PCAS, the President's Council for Advisors on Science and Technology, which wrote a report to the President where we saw that there were significant gaps and opportunities. This resulted in the President Obama issuing an executive order to combat antibiotic-resistant bacteria. And probably one of the highlights of my career is seeing phrases or recommendations that I have made translated into the executive order. I don't think I can ever really top that. But that's been really exciting, and seeing every month, seeing some of the fruits of that executive order trickling down, including the harmonization between the Food and Drug Administration and the CLSI breakpoints, now available on a website so that they can be updated on a regular basis. It's just a real delight to see progress being made on that side. So this is part of the executive order to strengthen national surveillance of efforts on resistant bacteria to prevent and respond to infections and outbreaks of antimicrobial resistant organisms, as well as on antimicrobial stewardship. And I discussed some of the antimicrobial stewardship efforts earlier today. So there was a national action plan for combating antimicrobial resistant bacteria. And then you cannot do anything without money. Okay, so financial support was critical, and in 2016, the president's budget asked for $264 million of new funding for antimicrobial resistance. Congress appropriated $160 million. So we're extraordinarily fortunate for that. And here, this is how the funding has been allocated. A large portion to state HAI and antimicrobial resistance prevention programs, the Antimicrobial Resistance Regional Laboratory Network, some funding for foodborne antimicrobial resistance, some funding for multi-drug resistant gonococcus and TB, and the Emerging Infections Program. And the blue boxes indicate the funding which we received in the state of Tennessee, which is part of my program or at the level of the state public health lab. So Tennessee received $6.6 million in the last financial year. There is no, this was just published at the end of last week, and there is no spreadsheet which compares different states, so I have to go through each individual one. But I would be very surprised if there's another state that has as much funding associated for healthcare-associated infections and antimicrobial resistance as we do in the state of Tennessee. When you look at purely what has been given to public health, these reports also indicate other academic centers which are doing research. And California has only got $700,000 more for state public health than the state of Tennessee. And then there's a huge difference in the population for California versus Tennessee. And I really attribute that to the diligence and the excellence of the team that I have a privilege of working with. So we have been very, very competitive. When I mentioned that funding, that is all competitive funding. So we get guaranteed one healthcare-associated infections coordinator for each state. Everything else above that, until last year, was competitive funding. We then, everybody from last year onwards, got an additional antimicrobial resistance coordinator for every single state. And then there was some funding, some partial funding to support state public health labs with regards to the characterization of carbapenem-resistant Enterobacteriaceae. So the CAR, that's combating antimicrobial resistance bacteria, action plan included creating a regional public health lab network that uses standardized testing platforms to expand the availability of reference testing services, characterize emerging resistance patterns and bacterial strains obtained from outbreaks and other sources, and facilitate rapid data analysis and dissemination of information. And the emphasis is really here on rapid dissemination of information. So it's data for action. This is not just for surveillance, for a nice report. This is data that people are acting upon as much as possible in real time. So this is the Antimicrobial Resistance Laboratory Network, and this has been really a focus of my attention over the last 12 months, has been really to go and bring up our state public health lab to be the regional laboratory. So the goals are to have gold standard labs with cutting edge technology, faster outbreak detection and response support, better tracking of resistance, and real-time actionable data to prevent and combat future antimicrobial resistant threats. So these are the 7 antimicrobial resistance regional labs. We're in the southeast. For those of you who don't know the geography of the United States, Tennessee is here. We're surrounded by 8 states. And we have Louisiana, we have Mississippi, Alabama, Georgia, Florida, and little Puerto Rico didn't even make it on the map, but we also deal with Puerto Rico as the southeast. The Michigan Department of Health does all the genomics now for tuberculosis to look at combating multi-drug resistance. So every state, every region, there are 7 regional laboratories, and we all have multiple states where we do testing. We perform core testing and testing for Neisseria gonorrhea. The Minnesota Department of Health Public Health Laboratory does core testing, doesn't do Neisseria gonorrhea, but they do C. diff, and they look at strep pneumo. The Wisconsin lab also looks at strep pneumo. And there's a few other labs which do Neisseria gonorrhea. So we've got 4 labs, 4 regional labs that look at Neisseria gonorrhea. So the core testing which is performed is looking at carbapenem-resistant Enterobacteriaceae, or CRE, characterization. CRPA is carbapenem-resistant Pseudomonas aeruginosa. We have targeted surveillance for emerging threats. And so that is something which is flexible and changes over time. And at the current time, we're looking at carbapenem-resistant Acinetobacter, as well as ESBL, Klebsiella, and E. coli, because we want to focus on looking for the mobile colistin resistance genes among those isolates. When this was set up, Candida glabrata was a focus, but as I'll discuss later, because of the emerging threats of Candida auris, basically it's become a Candida auris response instead, and Candida glabrata is just a small focus right now. We're trying to do as much, but it's really become a Candida auris response. And as I mentioned, Neisseria gonorrhea, strep pneumo, and C. diff. So previously, before this influx of funding, there were about 8 state public health labs that could perform characterization of carbapenem-resistant Enterobacteriaceae. With this, there are now 56 sites nationwide, 7 regional labs that are able to go and do that. And the idea here is really to improve infection control by detecting carbapenem-resistant infections, to characterize these resistance mechanisms, understand the distribution, detect novel and emerging resistance, and to understand the burden of these. Now, this is really key. The reporting of results, there is a very fast turnaround time. Within 2 working days of results, they have to be reported back to submitting clinical laboratories. And these are not used for clinical decision-making or a substitute for clinical lab diagnostics, but used to support infection prevention measures. The coordination between the lab and the EPI, which is the Healthcare Associated Infection Coordinator at each state health department, are absolutely essential. And the results may be an impetus for outbreak investigations, on-site facility assessments by public health to make sure that people have the appropriate infection control procedures in place, as well as colonization screenings, to coordinate colonization screenings. Now, in the United States, we use a term reportable and nationally notifiable. That terminology is slightly different to what it's used here. In the US, when we say something is reportable, that is from facilities or providers and laboratories to the state public health agency. Nationally notifiable is state public health agency to CDC. So we have had, previously, we have had 8 states that have routinely had the capacity to characterize, and we had about 15 states that started to make CRE reportable in their jurisdiction. We wrote a CSTE position statement, it's a Council of State and Territorial Epidemiologists. That's the way that we decide to make things nationally notifiable. And as of beginning of this year, beginning of January, carbapenemase producing CRE for E. coli, Klebsiella, and Enterobacter are now nationally notifiable. So let's have a look at some of the data from CDC. We have not yet finalized the data for 2017, so I'm going to show you the data for 2015 and 2016. We have an interactive dashboard for CRE and carbapenemase producing CRE. You can see the 2017 distribution, 2016, 2015, and then we also look at the proportion of isolates submitted to our state public health lab. So in Tennessee, we have required CRE, not just carbapenemase producing CRE, but CRE is reportable, has been reportable since 2009. The definition has changed over time, and we require isolate submission in Tennessee. So we want to track how many times are people actually, we look as to, have you reported it and have you also submitted an isolate? And then if they haven't, then we go and follow up either way. So this is an interactive dashboard. We can look down at a number to date for the calendar year, the number in the last 30 days, the number in the last 90 days. This is all based on the county of residence, not the county where the facility is located, okay? And we look at the annualized incidence per 100,000 of CRE, CPCRE, what the resistance mechanism is, for example, KPC or NDM, and the epidemiology in the United States is quite different to the one in Australia. We have predominantly KPCs over there, and IMPs are really rare. We look at the general distribution, Klebsiellas, Enterobacter, E. coli, and the percent isolate submission. So this looks at the raw numbers. In 2015, we had 105 carbapenemase producing CREs. You can see Memphis here, Nashville is where I'm located, Music City, and Johnson City is up in the northeast there. So in 2015, 105, nearly doubled that for 2016, but we're closing out the numbers. 2017 looks like we're around about 200. So we seem to have attenuated that really exponential increase from beforehand. And then looking at our incidence, you can see what's really striking here is the dramatic geographic variation across the state of Tennessee. And we're a really long, thin state. And I had always thought that we would be, since we have a major tertiary referral hospitals located in Nashville, that we would be a center for CPE, and that has actually not been the case. We had one case of CPE in 2015. We have had, I think, 4 in 2016, and we've got 6 or 7 in 2017. So it's been a fairly low incidence area compared to the rest of the state. We really have had major problems up in Northeast Tennessee and in the Memphis area, with emergence now in the Middle Tennessee area. What's also striking is that the distribution of genera is very different across the state. So in Northeast Tennessee, we basically have Klebsiellas. In the Memphis area, we've got basically Enterobacters. And, you know, how can you get this beautiful equal distribution for Nashville? That literally is what it was in 2016. We were equal Klebsiella, E. coli, and Enterobacters. So it's very, very, very different across the state. Very striking. So now we're going to be talking about containment of multi-drug resistant organisms. And this is really why we need a containment strategy. This looks at the march of KPC across the United States between 2001 and 2014. And so we really want to go and prevent that. And so the CDC developed this interim guidance for public health response to contain novel or targeted multi-drug resistant organisms, which is really a systematic, aggressive response to a single case of high concern antimicrobial resistance. So you don't have to wait to your second case or your third case. A single case requires a significant response, and the focus there is on stopping transmission. So it's a tiered approach for public health. There are specialized recommendations to identify if transmission is occurring, to identify any affected patients, to make sure that there's aggressive infection control measures which are implemented. And depending on what the pathogen is, sometimes environmental sampling is indicated. So here are some of the targeted pathogens for containment. Some examples are, we've got 3 tiers, tier 1, tier 2, tier 3. Tier 1 is Candida auris, vancomycin-resistant Staph aureus, and pan-resistant isolates. I'm glad I'm here in Australia right now. My colleagues are dealing with potentially the 17th case of VRSA in an infant in Tennessee. And we have a pan-resistant Acinetobacter that's resistant to everything that the facility tested, as well as all the antibiotics which were tested in our state public health lab. So they are implementing tier 1 right now for this. We have MCR1, so these are the colistin, mobile colistin resistant producing Enterobacteriaceae. Because KPC is so common, then basically all the non-KPC CPCREs are considered tier 2, and carbapenemase producing Pseudomonas. And then tier 3 is KPC CPCRE if it's not endemic. And so in Tennessee, we will have some areas where we will actually have even potentially a tier 2 KPC CPCRE if it has not yet emerged. So what we're trying to do is, we know where we've got it, and if we have not yet had it, we will have a very aggressive response to try and prevent the establishment of that. So these are the different tiers, tier 1, tier 2, tier 3. In green is it's always recommended. In yellow, if it's sometimes recommended. Red, if it's not recommended. And so it includes having a laboratory look back. Have you ever had this organism beforehand? Prospective surveillance, making sure that you identify any new cases. Healthcare roommate screening, broader healthcare contact screening, and potentially household contact screening. And on a case-by-case basis with regards to environmental sampling or healthcare personnel screening. And there's an algorithm to look at which healthcare contacts need to be screened based on when people were placed into contact precautions and what the organism tier is. So colonization screening following multi-drug resistant organism detection often involves healthcare roommate screening. I'm always really relieved when I hear that the patient was in a single room. That is music to my ears, because we then don't have to do as much healthcare roommate screening or broader healthcare contact screening. So let's have a look at some of this colonization screening. And when we made the recommendation in the PCAST report, we identified that one of the major barriers was that CDC had recommended doing these screenings, but basically nobody is implementing it. We hardly have any public hospitals. The private hospitals don't have a way of paying for it. So we try to remove those barriers. So the colonization screening is performed at those regional laboratories at no cost to the facility. The shipping of the samples of the swabs gets done by an overnight FedEx account that nobody needs to go and pay for, and we even ship the swabs out. So normally we work through the individual jurisdictions, state public health laboratory, but because this requires a really rapid response, the facilities actually will send those swabs directly, so from their facility to our regional lab. So for example, a facility in Florida will go and get the swabs, and they will send it to Tennessee. It will not be routed through the Florida Public Health Lab to make sure that we decrease the turnaround time. And then as soon as we get those results, we then feed that data back to the individual facility, to this state HAI coordinator, the portion who needs to go, the person who's responsible for the response in that state, as well as to that state public health lab. So the highest priority for us screening are screening roommates of new cases or screening contacts of contaminated devices. So if you had a duodenal slope which was contaminated, for example, performing a point prevalence survey for a new resistance or a first identification of CRE, and to perform point prevalence surveys if we suspect that there may have been transmission occurring. So this is an example not from Tennessee. This was a cluster of IMP in a nursing home where the index case was identified when this person from a nursing home was actually cultured during an outpatient visit at an acute care hospital. He was a nursing home resident for 2 years. The health department conducted multiple site visits to assess infection control practices and to review patient records. They did the first point prevalence survey where they screened a roommate and 29 other patients. They identified 5 suspected transmissions. During that time, all of them were patients on the same wing. All the isolates were indistinguishable pulse field gel electrophoresis. They were very aggressive with their infection control. And then point prevalence survey number 2 and point prevalence survey number 3, where they screened the wing with the inpatients. With the inpatients, they didn't identify any new positives. So we our standard way of responding is if you identify that there's transmission, we will repeat point prevalence surveys every 2 weeks. And you have to go through 2 negative point prevalence surveys before we say you don't need to continue doing any additional ones. This now is an example of one from an NDM and OXA48. This actually happened while we had a CDC site visit to us to examine what our ARLN was doing. So it was nice to be able to demonstrate it in action. So we identified an NDM positive one on a Monday morning. Within 30 minutes, the State Public Health Lab contacted me. We arranged a conference call with the hospital epidemiologist, the infection control professional. This was actually at Vanderbilt University Medical Center. We did a joint risk assessment as to what was the path of that patient throughout that facility, what was the patient stay, where did the patients go, decided who needed to be screened. We shipped the swabs to that facility. Hospital leadership needed to be informed. And, you know, what was really interesting for us was the way hospital leadership reacted. They thought, is this like Ebola? So we had to go and say, no, this is not like Ebola. This is going to be the common way of responding to it. But it alerted us that we really need to do major outreach to hospital leadership to make sure that they understand that this is a common thing that's going to be happening. The swabs were sent from a state public health lab to a facility. The patients were screened, and we had the results back. And this is not correct. This is, yes, at 47 hours from first notification of the NDM positive, we had the results back to the facility. All 12 persons were screened negative. And so that's what our aim is to get those results back for public health action, because every delay, you're going to miss the people who are now being transferred to other facilities and potentially seeding other places. So this one happened in November. This was our very first case of a VIM. Positive CRE. We traced the patient back to an LTAC. It was actually the lab report. This is a long-term acute care hospital where ventilated patients are looked after. These are areas where we have very high rates of multi-drug resistant organisms, because the patients usually have been in the intensive care unit at another hospital for at least 30 days. They're ventilated. They've been exposed to lots of antibiotics in there altogether. So these are areas of potential huge amplification of multi-drug resistant organisms. Now, when we actually received the isolate, it didn't say that the isolate came from the LTAC. It said the isolate came from one of our other acute care hospitals, because that's where the sample was sent. And so one of the big lessons for us here and trying to re-emphasize is to make sure that we capture the place where the specimen was collected, because any delay in us trying to trace that back is going to impact our response to that. So we performed a risk assessment, swabs delivered, specimens collected, transported back. This happened on a Thursday. I made the staff come back on Saturday. And so within 49 hours, at 49 hours after the identification of the VIM, we had the results back to the facility, and thankfully all those were negative. So these are just some concrete examples of what has happened with regards to that. Now, this is absolutely, totally breaking news, because I included these slides 15 minutes before this presentation, because they have just been emailed through to us. So this is the results that CDC has to date. With this initiative since January, over 8,000 isolates have been tested. Of those were 5,800 isolates of CRE. They've identified 1,878 cases of CP-CRE. Over 2,700 cases of carbapenem-resistant Pseudomonas aeruginosa were characterized at those labs. 128 carbapenemase-producing carbapenem-resistant Pseudomonas aeruginosa were identified. So 4.6% of the SERPA were carbapenemase-producing, 32% of the CREs were carbapenemase-producing, and the number of ARLN alerts sent were 429. So when the State Public Health Lab or regional lab identifies a non-KPC, carbapenemase-producing CRE, or it's a carbapenemase producer cannot characterize what the resistance mechanism is, that is a ARLN alert that gets sent down to CDC. And then CDC also checks to make sure that we at the State Health Department go and do the appropriate response in terms of doing the evaluation of infection control, implementing the screening colonization. So this is, our region is also responsible to bringing up to speed the state public health labs with regards to the resistance mechanism testing and the modified SIM testing, which is how we detect carbapenemase production. We've moved away from the carba-NP. The modified SIM test is just so much cheaper to go and implement. And so this is a map of how many reports they're supposed to be reporting on a monthly basis. The very pale ones show that we have not yet had any reports from just got an email from Louisiana. They expect to be finalizing their validation at the end of January. So you can see how many labs have actually been reporting and for how long they have been reporting to us. And these are the regional testing summary results. How many colonization screenings have occurred. So in the central part, the light blue part, there have been 62 colonization screenings. In western parts of it includes California, being 321. Here in the southeast, we have done 217 colonization screenings. And so it just gives you an idea of just the volume of work that has been done. So there's been a lot of attention built, given and in building the infrastructure to detect and respond to carbapenemase producing CRE. So this just shows the distribution of KPC. These are KPCs which have been reported to and confirmed by CDC by August of 2017. We've got a single state, Idaho, that doesn't appear to have had any yet, but every other state in the nation has identified KPC. This is the data as of June of 2017. NDM as our next most common resistance mechanism, 230 nationwide, 101 OXA48s, 41 VIMs, and 30 IMPs. Every single one of our non-KPCs in Tennessee has been an international patient who had received healthcare overseas or had come from another state. And there's only one person who came from another state. Everybody else was overseas. KPC is really the local one. We still got, we identified in November the VIM, and we do not yet know where that person is acquired. That's the exception there. So this is Kentucky and Indiana. This is a hotbed of VIM. So we knew that we were going to be very close to, we were at risk of receiving a patient with VIM. 20% of our patients in Tennessee that are hospitalized are out-of-state residents. We are surrounded by 8 states. So if there's new or unusual resistance, any of those isolates should be submitted to the ARLN. We confirm and characterize resistance mechanisms. If available, we, oh dear, no, I need some help here. Let's see. Top left? No buttons. No buttons. Okay, I'm going to try to move it down to here. There, how's that? If there's a new resistance mechanism, then CDC will issue a national alert and send an alert to the WHO. Oh dear. So for reference, in terms of what should be sent to the State Public Health Lab or to the ARLN, Appendix A in a CLSI M100 is a really good guide. One of the things that CDC is really concerned about is the really unusual resistance mechanisms, such as the colistin resistance, was published in academic papers. Public health and CDC knew nothing about these until it was published. Now, we don't want to take anything away from people doing publications. They're fine to publish, but please let public health know so we can go and do the interventions to prevent it from spreading. So there's a big push to make sure that we get those isolates sent to us. So I mentioned the targeted surveillance for emerging threats. It's flexible, covers a large variety of different organisms. At the moment, we're looking at the Acinetobacters and the ESBLs. And for that, that's not all testing. We are recruiting Sentinel laboratories. And for those, we're supposed to be thinking very carefully about which laboratories should we be targeting. So we're targeting laboratories from long-term acute care hospitals where you've got long-term ventilated patients, the ventilated SNFs at skilled nursing facilities. Again, very high-risk patient population for multi-drug resistant organisms from nursing homes and hospitals. So in Tennessee, this is the map of Tennessee with the different colors, and we divided up in emergency management system regions. So these are the ambulance services. And we hypothesized that the hospitals which are located in Region 1 are much more closely associated with each other versus the ones in Region 2, etc. Then we did a social network analysis where we looked at patient sharing. And what happens in patient sharing, not only direct transfers from one hospital to another, but what about if hospital A sends a patient home and then they go to hospital B? And so how these facilities connected to each other. And so this is looking at our hospital discharge data. And the hardest thing there in the United States is we don't have a unique identifier. Social security numbers are not always recorded. We do not have a Medicare number. So we had to go and work out what is our matching algorithm in order to go and validate the matching to make sure that we can identify a patient who was in one facility, that's the same patient in another facility. So when we looked at threshold of at least 170 transfers in 365 days, which is the 95th percentile, this is what the map looks like. And so we were thinking very carefully about ensuring we had geographic representation. We're looking very carefully at how our different facilities look connected to each other so that we would be able to get a really good sense and a real-time alert of what is going on in our state. So very thoughtful recruitment of our sentinel laboratories with regards to that. One of the facilities which we also recruited was St. Jude's Hospital in Memphis. It isn't actually that connected to other places. They see very high risk oncology patients, but not only from Tennessee, across the nation and worldwide. And so in fact, our very first non-KPC organisms, our NDMs and OXA48s, all came from St. Jude's. And so we knew, hang on, we've got these Central American countries which have got NDMs and OXA48s. They actually give us an insight of what is happening in those countries. And so we have also recruited them to be part of our Sentinel laboratory. So I'd mentioned that we look at, so that's how we recruited our laboratories. In addition, the social network analysis allows us to then go and trace back, hang on, where there was a patient previously potentially exposed, not on the individual patient level, but also if you don't know, they could have been exposed from somewhere else. Where did the patients which went to that facility come from? And patients from that facility, where do they routinely go to? And so I mentioned the hospital discharge database. That's one data set. The CMS data set, it's like from Centers for Medicare and Medicaid Services, which is really the United States Medicare, which is the over 65s. And so it's a subpopulation, but it includes nursing homes. Our hospital discharge database does not include nursing homes. So we wanted to get a sense of that. So the VIM case that I had mentioned, which was in the long-term acute care hospital. So we now have an app. It's a shiny app using R as the underlying infrastructure, where we can go and select the year, we can select the time interval, we select the name of the facility, we look at the downstream facilities, and we can select those thresholds so we can actually see how the facilities are connected. So this is looking at the CMS minimum data set. Here you can see, you can choose which data set we want to use. Do we want to use one which is everybody but exclude nursing homes, or we look at a subset which includes nursing homes? The time interval, which is at direct transfers, 30 days, 52 days, 365 days. The year, the name of the facility, do we want to see downstream, upstream, or both upstream and downstream, and what your threshold should be. And then we can go and look at the names of facilities, the number of transfers they had in that last year. So that LTAC has had 53 transfers to Vanderbilt University Medical Center. Vanderbilt University Medical Center has 1,019 beds. This is the location, etc. So this allows us to then understand where patients are likely to have gone to then go and target those facilities and say, hang on, you need to be really on the lookout for this novel resistance mechanism, because we'll understand what those transfers look like. And then we look at the degree of connectivity of an individual facility. So again, select specialty hospital in Nashville, which was this long-term acute care hospital where we identified the VIM. It's in EMS Region 5. It has 47 beds. The in degree is the number of facilities that had sent patients in 2016 to that facility. So it's 5 facilities that sent them in. Patients were sent to 4 facilities out. That's the out degree. The weighted in degree is the number of admissions they had received, and the weighted out degree is the number of discharges that they had sent out. And so it gives us an indication for risk assessments so that we can prioritize where we do our interventions. We looked at these measures of centrality when we worked out who we were going to target for our infection control assessments. So if you've got a facility that is highly connected, we want to be so sure that that is a facility that has excellent infection control so that they don't serve as a node for dissemination to other places. So now let's talk about Candida auris. This is the organism that causes me nightmares. It causes me to stay up at night. Mike, you asked me what is new and upcoming, and this is the organism I'm most worried about. So in our at the Tennessee regional lab, we tested 42 isolates. We identified 5 Candida auris, all from one patient from a facility in Florida. We had very rapid communication and interventions. There's been no secondary transmission identified to date. Unfortunately, we have no idea how this person got it because they are not linked to a facility that directly linked to a facility that has had Candida auris, and they had no overseas travel. In Tennessee, since 2017, Candida auris and rule-out Candida auris are reportable and require specimen submission so that we can go isolate submission so that we can go characterize and ensure that this is indeed Candida auris or not a Candida auris. And the vast majority of us, we have received things which were identified under VITEC, and 80% of the organism identification, 82% of the organism identification from the VITEC was different to what we identified using reference methods. So the VITEC is not performing very well. And I think we received 5 isolates for using MALDI, but there's the Brooker and there's the bioMérieux. We use the Brooker with the appropriate database. So ensuring that you've got the updated database with the updated software is really, really important. So why are we concerned about Candida auris? It's often multi-drug resistant. It's usually resistant to fluconazole, and some have been resistant to all 3 classes. If it's not resistant to start off with, it can easily develop resistance while the patient's on treatment. It's been transmitted within healthcare settings, outbreaks in multiple countries. It's closed down intensive care units. It causes persistent colonization. It tends to be on the skin in salt. It likes high salt concentration, so it likes the axilla and it likes the groin. So if you want to do colonization screening, that's what you go and target. It survives for long periods in the hospital environment. So it's sort of like the C. diff, but as a Candida. It also doesn't, our recommendations are to use a sporicidal agent for environmental cleaning because the normal contact times do not appear to be as efficacious. So using bleach for environmental cleaning around. And one of the other big things is that it's challenging to identify MALDI-TOF or sequencing is required. MALDI-TOF, you have to have the correct software and it has to be inside the database. And the other big concern is that a lot of times people do not perform speciation of Candida species. And so if you don't speciate Candida, you have no idea whether you may have a potential Candida there or not. So when we're looking at antifungal resistance, for Candida auris, 35% are resistant to amphotericin B, 93% to fluconazole, 54% to voriconazole, and 7% resistant to echinocandids. And when we compare that to glabrata, less than 1% are resistant to amphotericin B, 11% to fluconazole, and up to 12% to echinocandids. So it's a really nasty resistant Candida. So it's really a paradigm shift about how we think about Candida. Antifungal resistance here is in the norm. It thrives on patient's skin. We normally think about Candida as being in people's gut. This thrives on skin. It contaminates patient rooms and can spread really rapidly in healthcare settings. And here I will show you the epicurve. So in blue, you can see New York, green is New Jersey, pink is Maryland, and orange is Illinois. Just follow particularly the blue, the green, and the orange here. So this is from 2013, identified retrospectively in May of 2013 through August of 2016 when the initial alert came out. So this is what the epicurve then looked like in December of 2016. You can see New York had this massive increase, and we had some cases in Illinois. This is the epicurve as of August of 2017. You've got New Jersey now heavily involved, as well as New York and Illinois. Those three states are really the major hotbeds of Candida auris. So these are the data as of November 30th of last year, a total of 174 confirmed clinical isolates. There's 29 probable isolates. So that's a Candida hemolonii that was isolated from blood, and the isolate is no longer available. And so the reason why we say that that's a probable case is that Candida hemolonii doesn't usually survive at high temperatures. And so if it's an invasive isolate at a high temperature, it's probably not going to be a Candida hemolonii. It's actually probably going to be a Candida auris. And so that's the reason, that is the definition. And the Council of State and Territorial Epidemiologists, we published a case definition for use for states making things reportable. And we're currently working on making Candida auris nationally notifiable in the United States. In addition to these clinical isolates, 257 people were colonized with Candida auris. And this is going to be the next major bulk of work that the regional labs are going to be doing, is they're going to be not only performing colonization screening for the CPE and the Campinamase producing Enterobacteriaceae and the Campinamase producing Pseudomonas aeruginosa, but we will be involved in the response to Candida auris. So at the moment, it's very labor intensive, which will require actually culturing. We're investigating, looking at doing more rapid methods, the CAFEID system, and then there's also another system, which is sort of like a magnetic resonance piece, at trying to see if we can get a more rapid turnaround. So exactly the same flow of specimens and isolates and response as for CPE, but this would be for Candida auris. The New York Public Health Lab, the Wadsworth Center, as of June of last year, had already processed over 2,000 swabs looking for colonization for Candida auris. So it's a major, major impact. The regulators, the healthcare facility licensure regulators, which do inspections of hospitals in New York, have for 7 months been diverted from doing anything else in their job, purely looking at Candida auris and infection control. They have been on incident command for 7 months. So this is something that is really serious, and that's the reason it gives me the nightmares. And I really want to make sure that if we identify the first case, and we make sure that we are able to go and contain it. So these are the cases of Candida auris. In the shading show indicates just how many cases there have been. So it's really New York, New Jersey, which have been the major ones, and then Illinois. Florida has had 2 cases, and then there's just singletons around there. And so in Tennessee, we identified from a patient in Florida. We were the first ARLN to identify like one of those rule-out isolates. Interesting, we have 4 cases in the United States with recent travel. They've been from India, Pakistan, South Africa, and Venezuela, and those cases have involved urine and wound cultures. And those cases have occurred in Connecticut, Oklahoma, Indiana, and Florida, that initial first case. These are countries from which Candida auris has been reported, so we may have surveillance bias. So this is not a, it may not be complete, but we know what we know here. And so in the striped ones are US Candida auris cases linked to healthcare systems in these countries. The dark blue is transmission or multiple cases of Candida auris have been reported. And Australia still looks pristine at the present time. So as I mentioned, there's very common misidentification by instruments. The Vitek yeast systems use predominantly Candida hemolonii. The API system, Rhodoturula, you need to think about, especially if the red color is not present, or Candida sake. The BD Phoenix yeast identification system, again, Candida hemolonii. For microscan, we've seen a lot of Candida fumata or Villamondii, but it doesn't have these hyphae or pseudohyphae present. There's Titania and parasilosis. Again, no hyphae or pseudohyphae present. 30% of clinical cases in the US have been from non-bloodstream isolates, so urine, bowel, and wounds. And what's concerning here also is that non-sterile sites may not be worked out to the species level, so you do not identify it. So you've got an issue of no speciation being performed at all, or if speciation is being performed, it's being misidentified, which is a real problem here. So way to speciate sterile sites when clinically indicated. And then we have a recommendation, if you identify Candida auris at a facility in terms of infection or colonization, then we request that that facility speciates every Candida for at least 1 month until there's no evidence of any Candida auris transmission, to make sure that we capture any of those. And the recommendation from CDC is if a patient has had an overnight stay in a healthcare facility outside in the previous 1 year, potentially we need to even go up to 18 months, especially if you've got a country with documented Candida auris transmission, that you should do speciation. But that requires the healthcare system to identify that somebody has had overseas travel. And the adherence to that is probably suboptimal. So that is a challenge for us. So infection control is really crucial for stopping Candida auris. You need to have a environmental agent effective against C. difficile. Personal protective equipment is important, as well as naturally hand hygiene. From New York City, the lessons, so in New York, it's basically been New York City. They've had 26 hospitals which have had Candida auris. Their hospital epidemiologists, they just do not much else apart from Candida auris. There have been these are really basic things, but these are the things which have occurred. There have been opportunities missed with hand hygiene. There's been confusion about signage and PPE requirements, or PPE was not easily available. For environmental cleaning, shared equipment was not disinfected properly. It was the wrong product, or the contact time was too short, and there was a suboptimal communication at transfer. So none of these are earth-shattering, but these were the issues which were identified at those facilities. So again, remind you, this is a tiered response following Candida auris. It's a tier 1 organism. When you do point prevalence surveys, it's often found in multiple patients. This is a nursing home where they screened 65 patients and they found positive in 5. Another nursing home, they found 3. In an acute care hospital, it's 26. The places where transmission appears to be occurring the most is not in hospitals. It appears to be in nursing homes, in ventilated SNFs, and in the long-term acute care hospitals. That is where transmission seems to be occurring the most. Hospitals, occasionally some transmission, but it's predominantly aged care, predominantly in those long-term acute care hospitals and ventilated SNFs. In Tennessee, we're working on developing an XDRO registry, which we adapted from Illinois. We initially thought about this as being developed for carbapenemase-producing organisms. We're now expanding the scope to include all the tier 1, tier 2, tier 3 organisms, so that we will use our surveillance system is the database of record. We capture it in our communicable disease surveillance system. Every night there's going to be a download from that, populate the registry, and then you will have a query from a hospital or from a nursing home, initially manual or batch upload of a CSV file, hopefully then pinging it via ADT data, admission, discharge, transfer data, to get an automated alert as soon as a patient comes in. This is a patient who's known to have had CRE, a patient who's known to have had Candida auris, so that people can implement the appropriate infection control precautions. For Neisseria gonorrhea, we've all gone to culture-independent diagnostic tests. So this, the ARLN allows us to do phenotypic testing for those. And so we're one of the sites looking for Neisseria gonorrhea. Between April and November of last year, we tested nearly 1,500 isolates. 99% were susceptible to both ceftriaxone and azithromycin, or to cefixime and azithromycin. Only 70% were susceptible to both Cipro and Azithro. And 69 isolates met the ARLN alert criteria. So these are not resistant, but it's a creeping MIC. So the MIC for azithromycin is creeping up. We had 64 alerts with an MIC of greater than or equal to 2. We had 1 for cefixime and 4 for ceftriaxone for those MIC cutoffs. The other thing I'm involved with is CORA, which is the Council for Outbreak Response for Healthcare-Associated Infections and Antibiotic-Resistant Pathogens, to identify and develop a consistent approach to speed up detection of HAI and antimicrobial-resistant outbreaks across the healthcare continuum, to develop tools to improve outbreak investigations, contain outbreaks, and prevent the spread. This is our mission to improve practices. Ooh, this is, anyway, it says CORA at the top. I did not project well. To improve practice and policies for detection, investigation, control, and prevention across the healthcare continuum. And that is it. So, any questions?
Where to start? Yes. Do you know what, sorry, Marion was great, I'm just been trying to capture my questions. Do you know what system your lab's using for Kainer auris antimicrobial testing? Is it the sensitivity?
So we use the sensitizer, the trick for our susceptibility testing. We had significant issues in the validation of that, and when we reviewed their documentation,
the
trick people, their inoculum is less than a CLSI recommendation. And so when we increased the inoculum size, we decreased the number of errors and major errors, because we actually, for getting our state public health lab to come up to speed, to work, to be a regional public health lab, we had to validate all these results. And that is the one test that was the most difficult for us to go and do. And took, like, we kept on working and working and working, and then we find that the manufacturer's instructions. I don't know whether they have now put it into the appropriate general publication of it, but we have definitely raised that.
Well, I'll definitely keep that in mind, because I've ordered that kit.
Yeah, but it's been the area which that's been the major piece of concern for us, and like we literally have been spending like 7 months trying to validate this, and that was, we believe, the major issue. I think.
What are you validating it with? So you've got a control strain of Candida auris. Maybe we should talk later. Maybe this is probably
actually something that all of you might be interested in, which I didn't get a chance to go and talk about, is and this also came from the PCAST report. A recommendation was to have an isolate bank. So this is the CDC FDA antimicrobial resistant isolate bank, which is an amazing resource. I strongly recommend that you go and use it. And that I would encourage you to submit isolates to it as well.
So what's it called? CDC?
It's the FDA CDC antimicrobial resistant isolate bank.
And how do we get?
I can send you a link to that. They've got all these different panels for what you want to go and do, and it's used by diagnostic manufacturers. It can be used for validation, and it can be used also for drug manufacturers to develop antimicrobials. So we identified that there was an issue with regards to how do you validate a test? You go and call this hospital and that lab and trying to get your isolates together and things like that. The one thing to go and say about that isolate bank it's got challenging organisms. It absolutely has challenging organisms, and we use that isolate bank. So the those organisms are not run-of-the-mill organisms necessarily. Some of those are actually really challenging organisms.
The run-of-the-mills that the non-run-of-the-mills that reference yet, so the ability to do that.
Yeah. And the as we have been capturing more Candida auris, so the case of Candida auris which we identified on the moldy, it did not reach that threshold for reporting it as positive on our initial round. We had to run it 4 times over time. But we have an excellent relationship with our public health lab people. So they said, we can't confirm this yet at this threshold, but I want you to know it's, this far through it. So we acted already as if it were it. We implemented all the appropriate precautions. We said to the facility, and they said, we can't prove it, but we think it's really highly likely. And it's actually now gone into the database. And people are still working on improving that underlying database to make sure that they identify it all. And so there have been several other states who also had difficulty using the moldy where it doesn't quite meet those criteria. So I'm just letting you know, even though it doesn't reach that threshold, still don't exclude it yet, because we know that we've had issues.
Because I know that by Marion, I think their latest updated database will include it.
Yeah, we use the Brooker. So all the state public health labs use a Brooker. So it's been the one that, so I can't speak to the bioMario one. Any other questions? I'm happy to stick around for a little bit of time, so if others have any other questions and things. But thank you so much for coming.